Hi, I'm Tamara Paget, and this is presentation of case study number 17, acute pancreatitis. This is for class nursing 711, advanced physiology and pathophysiology. This presentation is a patient of FC who is a 63-year-old African male who came into the emergency department after suffering with left upper quadrant pain for about 3 weeks. However, in the last 3 days, it has gotten much worse, and the pain is radiating to his back and left shoulder. This is consistent with acute pancreatitis, where there's upper abdominal and left upper quadrant pain with an abrupt onset. It is unrelenting and gradually increases in intensity. Pain often radiates into the back, intensifies with walking or lying supine. Acute pancreatitis is not completely understood, but there is an inflammation or obstruction in or exposure to toxins that causes irritation to the pancreas. This is most often found in cases with alcohol use, gallstones, or cystic fibrosis. Those three things account for the majority of the cases. There are 80,000 cases annually, and the overall incidence is 19.5 cases per 100,000 people. And approximately 20 to 30% of all these cases are severe. The frequency of AP increases with age, and acute pancreatitis is classified into mild or severe forms. Mild is associated with minimal organ dysfunction and recovery without complication. Severe is associated with pancreatitis necrosis and can lead to organ failure and additional organ involvement. At the cellular level, after the inflammation has occurred, there's an activation and release of destructive pancreatic enzymes from the endocrine cells and ducts into the pancreas and the surrounding tissue. This causes autodigestion, more inflammation, significant cell death, and loss of pancreatic function. White blood cells that migrate to the area also release cytokinins, and this causes vasodilation and increased vascular permeability. And this irritates nerve, which then leads to the cycle repeating itself. So the more enzymes that are released, the more vasodilation and inflammation happens, which makes more white blood cells respond, which then causes more increased inflammation, and the process just keeps repeating itself until the inflammation has been subdued, treatment has been effective, or organ failure occurs. The assessment data for this patient includes extensive medical surgical history. He's had an angioplasty, cholecystectomy, appendicitis, hepatitis C for about 5 years. He's had hypertension for many years and a generalized anxiety disorder. He's allergic to penicillin, aspirin, and cats. Upon assessment, he appears restless and in acute distress. He's sweating and it just appears ill. He does have a fever. His blood pressure is actually low, and his heart rate and respiratory rate is high. He has dry mucous membranes with tinting, which suggests dehydration, which also goes along with his vital signs. This patient also is married with 8 children. He's a retired high school teacher and wrestling coach. He does have alcohol abuse for about 10 to 15 cans of beer per day for 15 years, which is concerning considering he does also have hepatitis C. He takes the medication for his hypertension, including antihypertensives, and he takes Tylenol #3 tablets, which then again, with his history of hepatitis C and alcohol abuse, is very concerning. He describes an approximate 8 to 10 pound weight loss over the past 1.5 months, and he's noted a reduction in the frequency of his bowel movements. Upon assessment, he is moderately distended with diminished bowel sounds, but does not have guarding. The pain is elicited with light palpation to his left upper and mid epigastric regions. He had extensive lab work done with elevated BUN creatinine, AST, ALT, alkaline phosphate, amylase, lipase, were all elevated. Additionally, his white blood cells were elevated. His hemoglobin and hematocrit were elevated, which goes to the dehydration. His triglycerides were markedly elevated, as was his glucose. His calcium and albumin were low, and his LDH was also extremely elevated. The role of the advanced practice nurse is to provide medical treatment such as IV fluids, ordering NG dissection, pain control, and antibiotics, and education on how to prevent acute pancreatitis in the future, as patients that have had episodes of acute pancreatitis are at further risk of developing that in the future. Also on education on stopping the use of alcohol and potentially utilizing Alcoholics Anonymous as support. Spiritual support should be based on the patient's desires and their comfortability with spiritual support, and even recommending the Serenity Prayer, which is based upon, the Serenity Prayer is not found in the Bible, but it is based upon Philippians 4:6-7. The 3 questions that I have for you is, what is the recommended antibiotic and analgesic prescription for the patients with AP? Secondly, what electrolyte abnormalities are commonly found in patients with AP? And lastly, is hyperparathyroidism a risk factor? Is that considered a risk factor for developing AP? Why and why not? And here are my references. I hope you have enjoyed this presentation.